So this is a collaboration among a lot of different people. Now, so Omar Agaisi and Suhail Al-Gabish are both in Jordan, Al-Tuna University. Laurent Sergerina is in the Kosovo, University of Pristina. Edward Yu was my teacher in my residency program in Western University in London, Ontario. And then Evie Jones Tuchera is in Ireland. She's a medical oncology resident. Hopefully will graduate next year from the program. Awi Assolin is from Paris, the head of department. He has a special interest in Merkel cell carcinoma. Osama Suet and Kimberly Hagel are from the University of Saskatchewan. They are medical oncologists, and they have kindly provide a lot of useful practical tips for treatment of this very rare cancer. And last but not the least, Professor Kieran Joseph from Cross Cancer Center at the University of Alberta. Next slide, please. Okay, now, I did not paste in the right paper. Sorry about that. This paper has been published from the Cancer. Next slide. Now, this Cancer is from NDPI. It's another sister journal, Current Oncology, but its impact factor is 5.2. It's a Q1 journal. And the Prisma has been done by, again, Mr. Omar Agaisi. And I'm doing the write-up because I myself is one of the international experts in Merkel cell carcinoma, being the up-to-date author on 5 skin chapters. I guess need no introduction. We all know that he's a nurse, very energetic, with a lot of interest in research. Next slide. So now, next slide. Merkel cell carcinoma is so rare that, next slide. Next slide, please. Okay, now, good. So Merkel cell carcinoma being so rare is a lot of clinicians in their lifetime that might only deal with a few cases. And only in major cancer centers like Memorial Sloan Kettering that there are more patients. But actually, the Memorial Sloan Kettering is the largest cancer center in America, and it has the most experience in Merkel cell carcinoma. The old days, almost the first landmark paper on Merkel cell carcinoma is from New York Memorial Sloan Kettering, where they first defined the stage as localized, and then the nodal, and then the distant metastasis. Now, this paper is a comprehensive review. It's not quite a systematic review. Let me tell you the difference. Now, systematic review is you have a specific question you need to ask. Say, you want to ask, is immunotherapy a good treatment? Does it improve survival? Then this is a specific question. But this is a very, very resource intensive method. You need a lot of time and to do the critical appraisal. So we finally settled down to do a comprehensive review because the journal had invited me over several months, and I keep on saying that I have no time to write it up. And only the last deadline or so, within 2 weeks, that I have to send in a manuscript. So within a limited time frame, we only managed to do a comprehensive review. Because a formal systematic review, you have to register to get a number in order to be a real qualified systematic review. this is the inclusion and exclusion criteria that Mr. Algaisi used. So they could be case report, observational studies, or clinical trial. Exclusion criteria, he only deal with English language literature. So, but I would think that most of the important papers are in English anyway. Like French, or they don't really have a lot of publication on this. So I'm pretty confident that we have included the most important advances in immunotherapy. Next slide. Now, summary. Immunotherapy, or most of them are done by immune checkpoint inhibitors. You may wonder, what are the other immunotherapies? They are not checkpoint inhibitors. They are like vaccines. They could be other drugs that could be used as immunotherapy. Now, for example, I think maybe like CAR T cell, I imagine it's a type of immunotherapy too. Or like you inject the patient's own T cell that has been trained or so-called engineered to be very powerful back to the patient. So it is a type of immunotherapy. But they are not immune checkpoint inhibitors. You have to know the difference. Now, there are different settings how you can use ICI, okay, immune checkpoint inhibitors. Like they could be given as neoadjuvant before the actual treatment, like radiation or surgery. Okay, those the radical treatment as such. So this is a Checkmate 358 trial. Patients were given nivolumab. 33 patients, half of them responded, and so they show over 30% tumor reduction. So they will enable surgery to be done, and then the surgical extent will be less, and the chance of positive margin will be less. You can imagine the beauty of neoadjuvant ICI. Next setting is to use adjuvant setting. It is the ADMEC-O, a phase 2 trial using adjuvant nivolumab. Now, what is meant by adjuvant is that you have the main treatment, could be radiation or surgery, but you add on something to it to increase the chance of killing those microscopic metastases somewhere in the body. So this is called adjuvant. The neoadjuvant, that means you give it beforehand. That's why you have the NEO, neo, the word before it. Now, the second study is called ADAM. It's a phase 2, phase 3 trial, adjuvant avelumab now, another ICI, in no positive patients after surgery or radiation. And it hasn't been reported. They only tell you that there's side effect, patient threw up, they have fatigue, they have itchiness. Now, the third study is DAM. It is just recently presented in ESMO, so it's hot from the oven. It's a phase 3 trial using adjuvant pembrolizumab in stage 1-3 Merkel cell carcinoma. Now, in ESMO, that just happened, it showed that the distant metastasis-free survival is significantly improved. But they don't have overall survival results yet. And the other endpoints are clinically non-significant. It maybe they haven't reached enough long-term follow-up yet, okay? Now, the third scenario is to use ICI as a primary therapy. Primary means that's the only or the main treatment. These are the Keynote 017 study and a Javelin trial, which is from the drug company. They reported overall 60% overall response rate. What is meant by overall response rate? That means you count a complete response, partial response. Okay, all the response, and then they're altogether 60%. That means 6 out of 10 patients have some response, as simple as that. And there are 40% 3-year progression-free survival. That means patient did not get worse, and they survived 3 years. With using first-line pembrolizumab or avelumab. So these two agents, interestingly, are also helpful to be used as salvage therapy. That means if patient failed previous treatment, you give the drug to them, and it is still useful. Next slide. Now, this is a prisma diagram. The words are very small, but trust me, it's all together 24 studies that were finally used to discuss ICI in greater detail. Next slide, please. Now, I haven't finished yet. Let me explain to you more about the summary tables, okay? For the STAMP study, STAMP, is an acronym for surgically treated adjuvant Merkel cell carcinoma with pembrolizumab. So all the uppercase are STAMP. That's why it's called STEM study. And it started in January 2019, completed accrual. Primary objective is to compare the recurrence-free survival and overall survival between pembrolizumab and observation. That means patients have surgery and just observed without giving adjuvant pembrolizumab. That means it's almost like experimental arm and a placebo arm. Okay? It's a phase 3 randomized placebo-controlled trial. Pembrolizumab was given 200 milligrams intravenously every 21 days for up to 17 cycles for 1 year. And radiation therapy is optional. Okay, the follow-up is every 3 months for 1 year and every 6 months for 5 years. So this is quite an interesting study and setup. And eligibility, adults more than or at 18 years old, stage 1 to 3 Merkel cell carcinoma, they must have undergone complete surgical resection within 16 weeks prior to randomization. Sentinel lymph node biopsy is required for stage 1 patients. They accept patients with unknown primary tumors if they present with regional node. The second objective is a distant metastasis-free survival, which I told you in the ESMO just recently showed significant benefit of this adjuvant pembrolizumab. Okay? Now, there is yet another trial that was not included in my slide. It's called IMET. Just like India, IMET, M-A-T. And it's a randomized placebo-controlled phase 2 trial of adjuvant avelumab in patients with stage 1 to 3 Merkel cell carcinoma to explore the efficacy of avelumab as adjuvant immunotherapy. So the details are avelumab 800 milligrams intravenously every 2 weeks for 6 months versus placebo. They would like to have 122 patients enrolled, so it's still ongoing in Australia and New Zealand. Major centers, of course, would be Peter MacCallum Cancer Center and Royal Adelaide Hospital. Eligibility criteria would be adults 18 or more with histological confirmed stage 1 to 3 Merkel cell carcinoma that have positive lymphovascular invasion only. They could have lymph node stage 2 and 3, but they do not have distant metastasis on PET scan or CT scan. What is PET scan? Is positron emission tomography. That means they inject some glucose that is tagged to a radioactive dye or whatever. And then for active cancer that are growing, then they will light up. That is called PET, positron emission tomography. So their primary endpoint would be 2-year relapse-free survival. Secondary endpoint would be your overall survival, disease-specific survival, local regional failure-free survival, distant metastasis-free survival, treatment toxicity, and quality of life. So I hope that I have given you simple explanations of what is most current in immunotherapy, which is hot from the press, because this paper was only published a month ago, and the ESMO data on the STEM trial was just most recently in the fall. So actually you save a lot of money. You save the registration fee for ESMO too, because you hear the latest finding. In conclusion, neoadjuvant ICI like nivolumab have high response and pathological complete response rate without delaying surgery. This approach is especially promising for bulkier node-positive disease and should be pursued in experienced centers. Experienced center, remember, or clinical trials with coordinated multidisciplinary care. In fact, all the Merkel cell carcinoma being so rare should not be treated by inexperienced doctors. They should go to a comprehensive tertiary center with multidisciplinary. And that would get the most money out of the buck. The most bang out of the buck, we call it. Next slide. Adjuvant setting. For resected high-risk Merkel cell carcinoma, adjuvant immunotherapy may reduce recurrence, just like the ADMET-0 that suggests improved disease-free survival, but immune-related toxicity are common. Therefore, you choose a patient that do not have too much comorbidity and make sure you monitor for toxicities. Next slide. Advanced disease. Those PD1 program death, okay, the abbreviation, program death. PDL1 is program death ligand. Okay, inhibitors are now the first-line therapy for advanced Merkel cell carcinoma. The treatment for Merkel cell carcinoma has changed. It's so much advanced nowadays. And they offer durable responses with 60% overall response rate and prolonged survival compared to the historical chemotherapy. There are special populations like immunosuppressed patients, those who are having autoimmune disease. They may still benefit from immunotherapy, although classically, immunotherapy were not given to patients with autoimmune patients, okay, or they are immunosuppressed. Well, they might have higher toxicity. Therefore, it would require a specialist to judge whether you should prescribe that or not. Next slide. Multimodal integration. Immunotherapy should complement but not replace surgery and radiation therapy. So that means by itself, immunotherapy is not the only treatment. It has to go hand in hand with all those local regional therapies like surgery and radiation. Chemotherapy is not yet dead. it might still have a role in Merkel cell carcinoma, and there are ongoing trials like Mercury that evaluate retifanlimab with cisplatinum and etoposide before surgery. There's also the Pandora trial testing the synergistic effects of chemotherapy with ICI. And yet another drug, a new anthracycline called amrubicin. You know, classically we have the adriamycin, right? We have epirubicin. We have the actinomycin D. All these are classical anthracycline, but these amrubicin is a new anthracycline and is being investigated. Next slide. So I'm glad that I give you a very concise summary of what is the latest on treating this skin cancer. Now, a lot of the logic has been used for melanoma, which is a more common cancer as well. Even for basal cell carcinoma, they are using a lot of the new systemic therapy like vesmodabtib. This actually have totally revolutionized the treatment of basal cell carcinoma. In the old days, some huge basal cell carcinoma, like the size of your hamburger, the meat in the middle, is not a death sentence. If you give vesmodabtib, the basal cell carcinoma will shrink. The surgeon may be able to take it out, all of them, margin-free. Resection margin-free. You can imagine the magic of modern medicine, and that's why we need to go to conferences to learn new things. We have to acknowledge the following team members of the International Oncology Cooperative Group, IOCRG, Professor Kieran Joseph, Dr. Calvin Wong, Professor Edward Yu, and myself, because I present on behalf of Omar Agaisi, who happen to be not available today. But I'm so pleased that you will be able to understand me well.